Imagine this. You're sitting in your final consultant surgery exam. The next 10 minutes, well, they could define your entire career. And your topic is femoral hernia repair. Let's get started.
Right, candidate. We've discussed the case, a 75-year-old woman, painful, irreducible lump in her right groin. You've correctly identified a strangulated femoral hernia. So, now I want you to talk me through this whole topic, as if you were teaching your junior registrars.
Certainly. I'd structure my answer around 5 key areas. You have to start with the foundational anatomy, because in hernia surgery, that's everything. Then I'd cover diagnosis and how to differentiate it. After that, the main surgical approaches, followed by the critical procedure for this specific strangulated case. And finally, of course, I'll cover the postoperative complications.
Okay, so let's start with anatomy. A femoral hernia is a protrusion through the femoral ring into the femoral canal. And understanding the rigid nature of this space isn't just important, it's absolutely non-negotiable. It's the very reason this is such a dangerous hernia.
A perfect place to begin. Define the borders of the femoral ring for me. Be precise.
Of course. Medially, you've got the sharp, unyielding edge of the lacunar ligament. Laterally, you have the soft wall of the femoral vein. Anteriorly, it's the tough inguinal ligament, and posteriorly, you have the pectineal ligament, which is sitting right on the pubic bone. Now, what's so clinically vital here is what those borders are actually made of.
You see, 3 of those 4 borders, the lacunar, inguinal, and pectineal ligaments, are basically bone or super tight ligament. They just don't give. They create this tight, unforgiving bottleneck, and that is the crucial insight. This rigidity is precisely why nearly 1/3 of all femoral hernias present as an emergency with strangulation. There's just no room to move.
Which naturally brings us to diagnosis. You know, telling a femoral from an inguinal hernia is a classic clinical challenge, but there's one key landmark that really cuts through all the confusion.
Exactly. It can be tricky, especially with obese patients. So talk me through it. What is the key physical sign you are looking for?
The absolute anchor point, your North Star, is the pubic tubercle. A femoral hernia is always going to emerge below and just medial to it. An inguinal hernia, on the other hand, is always above and medial. It really is that simple. Clinically, they also kind of have different personalities. Femoral hernias are often small, tense, irreducible right from the start, and they very rarely have a cough impulse.
Good. Now, a patient with a strangulated femoral hernia might not show up with the classic signs of bowel obstruction. Why is that? Define a Richter's hernia for me.
A Richter's hernia is a really nasty trap. It's what happens when only one side of the bowel wall, just a knuckle of it, gets caught in that rigid femoral ring. The rest of the bowel lumen is still open, so the patient might not be vomiting or constipated, but that piece of trapped wall is dying. It's insidious. It accounts for a huge chunk of strangulated cases, and it's a major reason why we have such a low threshold to operate on all femoral hernias.
Excellent. That is a very high-yield point. Now let's move on to the fix. You've made the decision to operate. What are your main surgical approaches?
So broadly speaking, there are 3. First, there's the Lockwood, or low approach. That's the real workhorse, a direct incision right over the lump. Very straightforward. Then you have the McVitie, which is an extraperitoneal approach. This one's a great choice for an emergency because it gives you excellent access to the abdomen if you suspect you'll need to resect some bowel. And finally, there's the Lostine, or high approach, which actually goes through the inguinal canal. We tend to avoid that one because you're disrupting a perfectly healthy inguinal canal for no real reason.
Let's stay in that emergency scenario. The patient has a strangulated hernia, and you're using the common Lockwood approach. This is the crux of the whole thing.
All right, candidate. You are the surgeon. From skin to skin, take me through your operative steps. Be clear and be safe. Okay, first, pre-op is crucial. General anesthetic and broad-spectrum antibiotics are already on board. Then, the incision, a 6-centimeter transverse cut right over the hernia. We dissect down carefully until we find that glistening, tense hernia sac. And here, this is the single most critical moment of the operation, opening that sac and inspecting the contents. If that bowel is black, dusky, or if its health is in any doubt, it must not be pushed back inside. That is an absolute red flag. It means an immediate conversion to a laparotomy for a full bowel resection. Now, if the bowel looks healthy but it's just trapped, our release valve is to carefully divide the tight lacunar ligament medially, and you're always wary of an aberrant obturator artery hiding there. Once the contents are safely reduced, we tie off the sac at its base. Then we repair the defect with strong, permanent sutures, closing that gap between the inguinal and pectineal ligaments, always protecting the femoral vein. After that, we close the wound in layers.
A very safe and thorough answer. But as we all know, surgery doesn't end when you put in the final stitch. A good surgeon is always anticipating what could go wrong next.
So what are the specific complications you would be vigilant for following this emergency repair?
I like to think about them in terms of timing. The most feared immediate complication is missed bowel ischemia. That's if questionably viable bowel was reduced. There's also, of course, the risk of damaging the femoral vein during the repair. Early on, we're watching for the standard things like a wound infection. And the main late complication for any hernia repair is recurrence, though it's actually less common here than in inguinal repairs.
Okay, so let's step out of the Viva simulation for a second and just summarize the absolute key takeaways here. 1. Know those 4 borders and understand that their rigidity is the root of the entire problem. 2. The pubic tubercle is your North Star for clinical diagnosis. 3. If you're dealing with a strangulated case, walk into that operating room mentally prepared for a bowel resection. 4. The lacunar ligament is your key to release the pressure, but the aberrant obturator artery is the hidden danger. And 5. The repair itself is a simple, strong closure between the inguinal and pectineal ligaments.
Very good. Okay, one final question. The bowel was dusky, but it pinked up after you warmed it with some saline, so you returned it to the abdomen. You're writing the post-op orders. What is the single most important instruction you must clearly communicate to the nursing staff for the next 24 hours? Think about that.